Thank you, Bryn. Next, we'll hear from Dr. Eric Holmboe. Eric is a internationally known medical educator, a general internist, and he serves as the Chief Research Milestone Development and Evaluation Officer at the Accreditation Council for Graduate Medical Education, or the ACGME.
Thanks. Well, again, thanks for having me today. I'm going to tell you a little bit about some of the things we're doing from an accreditation perspective to try to advance training in this particular area. I'm going to go through this in kind of a couple levels. I'm going to share with you some of the things we're trying to embed into accreditation standards and policies, and then get into some specific interventions that we hope will move the ball on this. So the first thing in regards to all training and residencies and fellowships in the United States, and currently at any given time, there's about 130,000 plus physicians that are either in a residency or a fellowship. And so and we now have over 11,000 accredited residency and fellowship programs. All those programs have to attend to what are called common program requirements. These are requirements that apply to any specialty at any level of training. And within those common program requirements, Section 4 relates to the competencies. And you heard throughout the morning the importance of making sure we define those competencies, and Arif in his comments, and also Bryn earlier on talked about the importance of competencies. I'm just going to highlight two that come right out of what are called the CPRs. You notice that interpersonal communication skills, at the end there, it's about end-of-life goals. So they have to learn to communicate with patients about what their healthcare goals are. So that applies to all people with serious illness, but also specifically calling out the end-of-life goals as well as being a core requirement for all specialties. Another example comes from systems-based practice. This is a competency that was put into place along with the 6 general competencies starting in July of 2001 as part of what was called the Outcome Project. This is one of the newer competencies, and it's been one of the more challenging ones, but I think it's also a critically important one. And the systems-based practice really gets at how do we work with others within the healthcare system, physicians, how do we advocate, et cetera. So you can see in this particular example that residents have to learn to advocate for patients within the healthcare system and attend to the patients' and families' care goals, including when appropriate end-of-life goals. So there it is again. So this is actually baked in the common program requirements, something that everybody's supposed to be attending to, not just palliative care physicians, as was nicely highlighted Bryn a moment ago. With each of these sections, there's a little box that comes in that section called background and intent. And it really tries to explain why these requirements are so important and why they're core across all training programs. So this is the background and intent for the competency section. And I just wanted to highlight the one area. It says a discussion about the patient's goals, values, and choices surrounding the end of life is one of the most important conversations that can occur. So again, you can see why this was put in. And you can also notice, as I said earlier, this applies to all specialties. This isn't just about palliative care, that this has to be core to our training across all of our residents and fellows. Part of the reason this is so important, and I think I'd like to highlight a little bit more that this kind of been implicit through the morning, but that in all of our trainees, even when they're out in practice, we're still learners. It is an intensely developmental process. I do not think we've done a very good job to attending to this development. You heard earlier from Laura about developing a competence-based or developmental model. Diane Meyer called it out, saying like we need to think about this more developmentally. And so our residents and fellows, and this is in the physician context, will spend the majority of their time with us on the steep learning part of this curve. So a lot of what we're teaching has to be embedded as part of their training. It is not going to be just sufficient to have a lecture on it. That's important, but they got to take it to the bedside. So that would be characteristic of some of the work James Tulsky is doing up in Boston, where he's actually incorporating some of these communication skills at the bedside. That's where we need to go, because it is an intensely developmental process. And if you didn't get this training in residency, it's going to be intensely developmental when you're out in practice. The question is, how do we support that? How do we have people take it to the bedside so that they can use it? And to help us kind of guide this developmental process, we've created something called Milestones. So we've taken the competencies and we've created these things called Milestones, which are nothing more than developmental narratives, roughly based on the Dreyfus model, or what's called stage model of development, where you move from novice to kind of expert. And the goal is to describe in words what that developmental trajectory looks like. And one of the things that's happened the last couple of years is that we got interprofessional groups together to take a look at 4 of the 6 general competencies: professionalism, interpersonal communication skills, practice-based learning and improvement, and systems-based practice. And we harmonized that, saying we think that every specialty needs to attend to these things. Yes, there will be contextual differences within that specialty, but these are so important to being a physician. No matter what specialty you're in, you have to attend to this. And so this is one for patient and family-centered communication. Again, I think it highlights that this isn't just for palliative care or for geriatrics. Everybody has to be good at this. And even if you're a pathologist, you may have to deliver bad news, or you may need to work with an interprofessional team because you're serving as a consultant. You still need these skills. And so our goal during training is to have people reach what is level 4, which is essentially proficiency in the Dreyfus model. That's the recommended target, is to get people to this level by the time they finish. And this is for everybody, not just those within a particular subspecialty. These harmonized milestones are now being used as we revise our overall milestone project. We're now 6 years in. These are now being used as the starting point or template for all specialties as they revise or move into Milestones 2.0. And the good news is that these are being adopted. And so we'll have some commonality, some harmonization across the specialties for the first time in this project, and we're excited about that. But we also have the specialty of hospice and palliative medicine. As you heard earlier from Arif, it's a relatively young specialty. In fact, certification was not offered in the specialty until 2006, when a series of boards at the American Board of Medical Specialties endorsed this as its own specialty. So it is a relatively young specialty in comparison to many others, and multiple specialties actually have a training pathway to acquire certification in hospice and palliative care. It's over 10 different specialties. This is just an example of a milestone from hospice and palliative care. This community's been amazing in developing this. This is a wonderful resource for everybody to use that describes the developmental trajectory in this particular field. This will also be helping to guide Laura Dingsfield's project that you heard about earlier, about what does it look like to be developmental. And that means having a mid-career or maybe a blended model or an interrupted model, that if you know what the trajectory is, we can think differently about training instead of being locked into the kind of time-based model that was brought up again by Diane earlier this morning. So what the milestones help us do, again, they're just one tool of many, is to help us integrate the curricular and assessment experiences in this developmental journey for our learners. And so that's where they've served an important role. It's still very early in the process. Things are still very messy. But what's also important about the milestones is that they're beginning to measure things previously we weren't paying enough attention to. And we're now trying to look at educational outcomes and things other than medical knowledge. Don't get me wrong, I worked for a certification board for 9 years. Knowledge is important. It's essential, but it's insufficient. And we need these other skills. The other thing Milestones are really helping with is something Arif alluded to earlier, and it's something that worries me a lot. We just don't observe people in these skills. He has himself pointed out that he doesn't really get any feedback or observe doing it compared to his procedural colleagues. That's a culture change we're all gonna have to get more comfortable with. A lot of the work we do is around direct observation, again, taking it to the bedside, because you have to practice these skills over and over. Taking a test isn't gonna cut it. Right? A lot of this is applied. And so the only way to watch if somebody can actually do something is you got to go with them at the bedside to the patient. This is the kind of national data system. This is the kind of the way I look at our world. I work on the right-hand side of the diagram in accreditation. There's certainly the certification piece. But the most important thing that happens for us in the context here of residency and fellowship is inside that rectangle. The combination of assessments that generates data that comes into something called a clinical competency committee that then makes a synthetic judgment about where a learner is developmentally. That should then lead to feedback to the resident or fellow, that's the FB in green there, but also feedback into the program to help the program itself get better. And we now have national milestone data that we're not only beginning to look at from a research perspective, from educational outcomes perspective, but this is now becoming a feedback loop to programs. For the first time, we have learning analytics that'll be available to our core specialties to see how they compare against their peers nationally and how they're performing in each of these competencies. The other thing that's really important to notice about the slide is you'll notice residents have to be an active agent in their own learning. I'll come back to that in a minute. Here's another really important point that came up. I work for an accreditor. I'm the professional self-regulatory world. We're really good at writing policies and stuff. I used to work for a board, really good at writing a test. Here's the bottom line. At the end of the day, the most important decision is made by the training program. They decide who enters the workforce. And if somebody comes out insufficiently prepared and worse yet cannot get certified, anybody want to guess who they're more likely to care for? They'll take care of the poor, because that's where they can get a job. And so we inadvertently can exacerbate disparities if we're not careful in this self-regulatory world. And so preparing programs to train effectively is really important. And the milestones are just one piece of many and not journey. I want to just kind of end with a couple things going on. So you heard about a pilot from Laura earlier this morning. We have a mechanism through the ACGME called the Advancing Innovation in Residency Education pathway that allows folks to bring innovative ideas to think differently about training. Laura's is one of those. She was one of the early adopters of this pathway. There is also another in hospice and palliative care that's also very interesting, being run by Amos Bailey out in Colorado, that will allow folks who are mid-career out in practice, particularly in communities or rural areas, to train in situ through distance learning. They will come on site to do simulation. They'll use a portfolio type process, but they will be able to continue their work in their specialty as they acquire certification in palliative hospice care. I am very excited about this pilot, as I am with Laura's. Laura didn't tell you that she's also looking to expand her pilot, which I think is fantastic. So we have two very interesting pilots going on. We're very excited about those. We have had a pilot in geriatric hospice and palliative care for 7 years, run by Helen Fernandez in Roseanne Leipzig. We also have others that are beginning to crop up in things like sleep, which we have mid-career, what are called blended or mixed models of training. So we're excited that this pathway is out there. We encourage people to use it, and we're beginning to see interest in it expand. We also do a fair amount of work in preparing our faculty in assessment. And again, this is a theme that's coming out through the morning. What's interesting is that we try to help faculty get much better in assessment. We spend a lot of time around direct observation and feedback. And what we've incorporated into that training is a simulation experience where faculty will actually watch a standardized patient, a standardized resident. They'll observe that encounter and then give feedback. One of the stations is actually breaking bad news. Part of the reason we put that in there is we know this is an area that many faculty themselves are struggling with. Even in our course, when we're teaching the workshop portion prior to the sim, we ask how many people are familiar with the framework spikes for breaking bad news, just a basic important tool. Only about a quarter will raise their hands. And so we have a faculty workforce that just aren't up to speed, and we're using faculty development and assessment as a twofer, also helping people begin to work on their own skills. And Jen Kogan and I, along with Lisa Conforti and others, published a paper a couple years ago showing the kind of twofer effect by working with folks in the context of assessment. It actually helps them in their own clinical skills, and they can be taught to take this back and apply it in their own practice. We also now have 11 assessment hubs around the country where we offer 2 to 3 day sessions in direct observation training. All of those hubs across the country use the Breaking Bad News Station and bring in the concept of serious illness. I think the other thing that's really important as we approach our work is like, how do we look at this through a service lens? Healthcare is very much a service profession, and so for us, we use this lens of co-production, and I think there's been various elements of that this morning. This is just the definition of what it means to have a co-produced service, right? It always involves two parties, and so when you're talking about working with patients with serious illness, that is a co-produced service. It's a deeply co-produced process. And so 2 years ago, Marba Talden and others wrote a very nice piece in BMJ Quality and Safety about this concept of co-production, where patients and families need to co-execute, co-plan through civil discourse with the healthcare team, the professionals, to produce that high-value care. And end of life is an example where co-production is critical. That's embedded within a healthcare system. But as many of you have already pointed out, it's also embedded within the community. Many of the resources that are needed come from the community. My personal story is that both my parents died at home, and we're fortunate to have home hospice. That's the good news. The bad news is getting them into home hospice was a nightmare. It only happened because I executed the system but also I had friends in the community who were actually able to connect me with people to get them that care. So we think about co-production from an educational perspective. How can we work with our residents, our faculty, our fellows, et cetera, to co-produce education to produce higher value? And I think we're going to have to use co-production and co-learning processes to get our not only practicing physician workforce up to speed, but also our faculty. Just want to encourage you, there's lots of resources on our website. Feel free to use it, including the Milestones, lots of resources on education. We would encourage you to use that. And I will stop there and turn it back over to Miguel. Thank you.